I'm Polly Warren and welcome to the Positive Perimenopause podcast. This is the place for some positive inspiration to help you through the rollercoaster ride of perimenopause. I truly believe that with the right support, knowledge and wellness tools, you can feel your best yet, because I'm learning this life phase can be a truly exciting and often pivotal time of life. With every episode, my mission is to support and empower you to own your menopause, because it's time to start taking care of the most important person, and yes, that's you. So thank you for being here and sharing your time with me. Now let's dive in. Hello and welcome back. I hope you've had a good week. I'm very excited this week because my 15-year-old son finishes his GCSEs. Hooray! I think I'm as excited about it as he is. It's been a bit of a slog, but he's got there, so I'm dead chuffed for him. I hope you enjoyed last week's episode, which was all about how to integrate healthier habits into your everyday life in a really easy and sustainable way. It was all about habit change and behavior change. So yeah, let me know how you get on with that. And if you haven't listened, I really recommend it. There's some real juicy bits in that one. Now, this week, I talked to Dr. Sian Evans. Sian is a GP, a general practitioner here in the UK in London, but she also has a particular interest in menopause. Being a perimenopausal woman herself, she's also got children, she has elderly parents, and so she fully understands the juggle of life at this stage of life. And I really wanted to get someone from the medical profession on the podcast because HRT, Hormone Replacement Therapy, here in the UK is one of the recommended treatments for menopause and perimenopause. But there also is so much controversy about it because there was a study done back in 2002 which linked HRT with breast cancer. So I wanted to speak to Sian, clear some of that controversy up and really hear about some of the risks and benefits of taking HRT from a medical perspective. I think you're going to find this episode really useful. And if you feel like you have a friend or know somebody who could really benefit from this information, please feel free to recommend this episode to them, because the more we know about this stuff, the absolute better. So without further ado, please welcome Dr. Sian Evans. So Sian, hello. It's so good to have you here today. Thank you for joining me.
Thanks for having me, Polly. It's lovely to be here.
So Sian, it would be a really useful place to start, I think, by hearing from you. I know you're a GP, but actually even GPs go through menopause and have their own perimenopause story. And it would be really fantastic just to hear a brief account of your own perimenopause journey, if you wouldn't mind sharing.
Absolutely not. It's really interesting, isn't it, that we assume that just because we're medical, we'll pick these things up. And I think you kind of slightly forget that you're growing older and you're busy with life. And I've got 3 children. I work as a GP, but I'm sort of compressing my GP day within school hours. I'm pretty busy school hours, and then I run around being a mum. Got older parents, one who's sick now. So, you're just very busy. So you don't really think about yourself very much. And I was incredibly tired, but that was very, very easy to explain. I never had problems with my sleep. So I was sleeping well, but I just exhausted all the time. And then I had a lot of joint and muscle pain. But, it wasn't anything that I couldn't manage with a lot of stretching of an evening. But I didn't really, I invested in a Theragun and did everything I could for my joint and muscle pain, but didn't really stop to think menopause because I have a marina in situ and I didn't have any signs from periods. And I didn't really have many hot flushes. And then in the summer, I developed really, really marked palpitations, which are quite frightening. I have an underlying health condition that possibly puts me a little bit higher risk for problems with palpitations. So I was sort of very, very surprised by these palpitations, but didn't quite know what to do with them. Kept on checking my pulse and thought, what's going on? What's going on? And then I just stopped, and I don't know why. I think I had some holiday, and there's just that extra time and space to reflect. I guess you really know that as a coach when you actually take time to stop and reflect rather than just pursuing things. And I just suddenly realized I was menopausal, and it just all made sense. And once I started, there's obviously all the self-care stuff that's incredibly important, but actually once I started estrogen, the palpitations completely disappeared pretty much straight away, and all the joint and muscle pains did. The fatigue improved. It's still there. Let's be realistic. Life is still busy, and that's not going away. But certainly for me, it was pretty life-changing in many ways. It's interesting, isn't it? We just ignore these symptoms sneaking up on us. I mean, I'd had for a few years the occasional sort of chin hair, or a bit of acne on my chin that I never seemed to be able to get on top of, or just lots of little clues that I just wasn't seeing. So it's so interesting that even when I see it in other people, I didn't see it in myself.
Yes, it's so fascinating, isn't it? We just don't see it on ourselves. So yeah, you mentioned the palpitations, the joint pain, the fatigue, the chin hair. Oh my goodness, where do they come from? It's like suddenly you have this really long hair, which it's like you had no idea it was even growing, and then you have to get it. Oh my gosh, that's not one
and
of the.
you only notice when you know you're somewhere where you can't go and sort it out, and you know it's hanging there, and you're sort of trying to cover it with your hands. Somehow it suddenly comes out 1.5 centimeters long from nowhere.
I know. I know. So those obviously are some of the symptoms you've mentioned of perimenopause. And as we know, there have been listed over 35 symptoms. So for someone who is in perimenopause, or someone who is not sure if they're perimenopausal, what can we do? What would be your advice? How do we know that we are perimenopausal?
Well, I think it's just about, first of all, recognizing it's not that you're suddenly in perimenopause. Menopause is obviously, that's a defined moment, but we can only diagnose it after the event, because menopause is when your periods stop. Perimenopause is a very, very long and slow running. And, you'll have periods of time where you feel better and periods of time where you feel worse, but it's a really long continuum. And, I remember probably in my late 30s having a laugh with my friends about the occasional chin hair that sprouted out of my chin. I didn't think, oh, there's the start of the perimenopause. So it's a very, very low and slow run-in, and it's really about how it affects you personally. And I see people who really don't notice many symptoms, and then I think it's very important then to have a discussion about maybe health benefits of HRT. But actually, for a lot of us, it's a very slow run-in, and it's about noticing and realizing and asking for help if we're struggling, really.
Yeah, it's the asking for help bit is a big one. It's because I know from my own personal experience, I had 4 years of feeling pretty bloody crappy and just soldiered on and felt like I was okay enough to soldier on. And just for some reason, I still don't really know to this day. I didn't talk about it to anybody, although behind the scenes, I really wasn't in a great place. And it is this sort of thing that so many women have, that feeling of like, oh, well, I've just got to keep going. I'm not going to ask for help. I'll look weak if I ask for help. But actually, that is probably one of the worst things that we can do. The more help we can ask for at this time, actually, is going to give us the support that we need and help us to recognize that we need to take time for ourselves, isn't it?
Did you know it was perimenopause, Polly?
No, I had absolutely no idea. No clue. I'd never heard of perimenopause. I thought menopause was way off in the distance. And yeah, I was really struggling with, it was my moods, it was my joints like you, so many different symptoms. And because I didn't talk about it, I didn't really have any sort of a comparison with anybody else. Yeah. I just thought things, my body was getting older and it was aging, and I was busy. I was teaching. I had 3 small children. My husband worked away. I was busy. And I think that's the thing. So many women are so busy because of the way that we live these days. We don't give ourselves a moment to stop and assess and reflect on what's going on, which sounds a bit like you. That's what we're doing. Whereas the message really, I think, needs to come across that actually we just need to slow down a little bit and get more in tune with our bodies and listen to what they're saying.
Yeah, and just understand what's going on for ourselves. Speak to our friends, educate our friends. Educate yourself. Get
Yeah.
yourself a really good book about it, or you
Yeah.
know, if you don't understand what's happening, it's very, very, very frightening and confusing for a lot of
Yeah.
people. People think they're losing their minds because their anxiety gets so bad, or they think they're getting dementia because their brain fog is so awful. And you see some very frightened people actually, because it is very distressing.
It really is. I mean, my mum has now been diagnosed with Alzheimer's and vascular dementia. And at one point during my own journey, my memory was absolutely horrendous, and I would forget so many different words. It was on the tip of my tongue. And even doing this podcast slightly gives me the fear, because it's like, what if I just can't think of the word to say or the question to say? But because I didn't know anything about it, it made the whole experience even more scary, because I was thinking, oh my goodness, I've got early onset dementia. But now I realise it wasn't at all. It was my hormones.
Yeah.
So, Sian, could you just, and I have talked a little bit about this before on the show, but could you just, coming from a medical point of view, just give our listeners a bit of an overview of what is actually happening during perimenopause in terms of our hormones? Because as you say, when we know what is happening on it, really does help remove some of that fear.
Well, I think understanding that as we sort of come to the end of our reproductive life, our estrogen level starts to fall, and we have estrogen receptors all over our bodies. They're in our brains, they're in our hair, they're in our nails, they're absolutely everywhere in our body. That's why the symptom pattern is so wide. So that's starting position, and then also understanding that as we go into the perimenopause, it's not just a gradual decline in your estrogen. It's sort of like I have a really good friend that describes this as a flickering light, and I think it's such a great analogy. Your estrogen sort of turning on and off and on and off. Now, if you sit in a room with a flickering light, it's incredibly distressing, isn't it? It's like you just want to shut your eyes. It's horrible. It can make you feel anxious. Certainly wouldn't help you sleep, etc., etc. And then it's sort of flickering light that's turning on and off and then slowly fading away. Now, in menopause, the estrogen levels are very low, but it's not flickering in the same way. So, in the same way eyes can accommodate to the dark a little bit, it's not great, but it's certainly better than that constant flickering. So, actually, perimenopause can be, I'm not saying always is, but can be more distressing than menopause for many women. Once women get through the menopause, they often feel a little bit better. So, this falling off of estrogen level is really quite sort of disabling. And that also explains why some days you feel a little bit better and some days you feel absolutely terrible. And it also explains why a blood test is useless, not useful, because actually you might capture you on a good day and actually doesn't reflect the bigger picture, or on a good hour of a day. So it's about listening to your body and listening to those symptoms, really.
Yeah, absolutely. I have heard some people mention that during perimenopause, actually, sometimes our estrogen can be quite high because it's fluctuating so much. And our
See,
progesterone declines more gradually, but actually declines first. Is that correct?
well, I mean, again, when you're looking at estrogen, you've got to remember that estrogen and progesterone fluctuate through your cycle. So it really depends where you're measuring something in a cycle. For example, if we were checking progesterone on a woman to see if she was ovulating, we would only ever check it in the second half of the cycle, because it's higher in the second half of the cycle when your womb is being told to stay nice and plump and healthy to develop a baby. And estrogen spikes mid-cycle when you're ovulating. So these measurements of hormones aren't terribly helpful in that sense, because you are still cycling in perimenopause. You're just maybe not cycling as regularly, and your hormone levels aren't as sort of healthy at that point. So I would focus less on the actual levels and more on how you're feeling and your symptoms, because that is so much more important than measuring a number.
And I do think a lot of women get quite upset when they're not offered a hormone test when they go to the doctors. But the nice guidelines state that it's after, if you're 45 and over, you don't need to have a hormone test. But if you're 45 and under, you do. Is that
So
right?
So I think certainly under 40, I'd be wanting to be sure about making the diagnosis of this sort of premature ovarian insufficiency. But between 40 and 45, I'd probably be doing other blood tests to make sure I'm not missing something else in a woman. But remembering 1 in 100 women under 40 are perimenopausal or menopausal. So it's not uncommon in the 40 to 45-year-old group. In fact, it's incredibly common in that group. So I would do some blood tests to exclude other causes, but a normal FSH, which is the hormone that we use to measure menopause, would not tell me that that woman was not menopausal. And in fact, if everything else was normal and they had some good going symptoms, a trial of HRT is a really good way to work out what's going on. Do that lots of the time. If someone's got a bit of a sore stomach, we might give them some antacid and go, oh yeah, it was, that was heartburn that you had then. We use treatment sometimes to work out what's going on. So I think a trial of treatment is probably more helpful than a blood test, even in a 40 to 45-year-old woman.
So if someone listening feels that they might be perimenopausal, or they just notice changes happening in their body. Maybe they notice changes happening to their cycle. They might be listening to this going, oh my gosh, I've got terrible joint pain, or my moods are all over the place, or they're very flat, or I've got heart palpitations. What's the next step they should take?
So I think educating yourself is really important. Louise Newsom is a big advocate for menopause education, and she has set up a sort of charity. She does have a branch of her business is private menopause care, and I would advocate that you should be able to get care on the NHS. But she has an app called Balance, and she has a lot of resources on her website in the library, podcasts and information leaflets that are really helpful. There's also lots of good books out there, and there's also the Women's Health Concern, which is the patient arm of the British Menopause Society. So there's lots of information. Have a read and have a think about what might be helpful for you. It's not all HRT. I do advocate HRT, obviously. I think it's a fabulous replacement of the hormones that we've lost. But you do need to have a think about your lifestyle, your exercise. Women do very, very well with regular exercise in terms of osteoporosis prevention, mental health, and hormonal stability. There's lots of good evidence around diet and avoiding sugar spikes. And some women find certain supplements, like taking magnesium at night, very helpful. So there's lots of really good things that you can be doing that isn't HRT. But I'm guessing, Polly, you probably have lots of other guests coming on to discuss a lot of the lifestyle intervention. Maybe we should have a think about HRT. Is that what
Yes, absolutely. Yes. So I've spoken to lots of people who were looking at the different lifestyle interventions. So yeah, let's talk a little bit about HRT. So for those who don't know, it's hormone replacement therapy. Maybe a good place to start is, what's the difference between there's body identical HRT and bioidentical hormones? So body identical hormones and bioidentical hormones, because I think because they sound so similar, they're very easily confused.
Yeah. So the term bioidentical was coined, and it's a private system where they say that not all women are the same, which I completely agree with. So you get little women and tall women, and we have different metabolisms. So therefore, they produce products that they say match the woman's personal needs, and within that, therefore, they may have varying levels of estrogen, progesterone, and testosterone. The slightly tricky thing with these products is that they're unregulated. So they're made up in labs that don't regulate the quantity. So there may be insufficient progesterone, for example, to protect your uterus against endometrial cancer. So what you want to look for is people that do body identical HRTs. That's what's advocated by the British Menopause Society. Lots of private providers do offer this as well, but so does the NHS. So you can get it on the NHS, which is key. And these hormones are the same as the hormones that your body produces. They are generally, therefore, lower risk in the way that we prescribe them, and they are very well tolerated in the way we prescribe them. But most importantly, they are regulated. So we know you're getting the right doses, for example, of progesterone, to protect your womb.
And just for anyone listening in the US, around the world, because I know that there are a few listeners that I've got in the US, that we're obviously talking about what's happening here in Britain on the NHS, our National Health Service, but I know in the US, bioidentical hormones, I think, are more widely used than
I,
these body identical hormones.
so I do have a couple of friends even who use bioidentical hormones despite my protestations. I think it's tricky, isn't it? If you're going to be doing something that isn't fitting within the licensed and regulated hormone treatments, then you put yourself at risk because the evidence isn't there to support some of that use. You don't know that the product is always the same that you're getting, and also, but in that scenario, for example, one of my friends will have a 6-monthly ultrasound to check the lining of her womb. That makes it safer in some degrees because they know that the lining of the womb isn't getting thicker. But I mean, if it feels very unnecessary to have an invasive test every sort of 6 months, having a transvaginal ultrasound scan just to check that your lining of your womb looks okay. Why not use something that's well evidenced and regulated? I don't know, in all honesty, in the US how they regulate their bioidentical hormones, if the labs are regulated in a different way, but it's certainly not regulated in the UK.
And these hormones are made from wild yams, aren't they? They're made from a natural product. Because I think, which they didn't used to be in days gone by. They used to actually be made out of horse urine, which sounds disgusting. Right. But now they're actually made of wild yams. So other than the process that they go through to kind of turn it into a gel or a patch, which is obviously a process, they are pretty natural. It's pretty natural.
Yeah. And they match the hormones that your body's producing.
Okay. So, Sian, the reason why so many women are still very wary of HRT, I believe, is still because of a study done back in 2002 by the Women's Health Initiative, which falsely reported the figures, the stats, that HRT increased the risk of breast cancer. Perhaps you could just talk to that a bit and put women's minds at rest if they're still hearing that, because there are so many myths circulating still. A very quick break to ask you to hit the follow or subscribe button if you haven't already. And if you're enjoying this episode, I'd be super grateful if you could hit those stars and rate it too. Thank you.
So I guess if we refer to that study in the first place, that study wasn't set up to study breast cancer risk. It was set up to study cardiovascular disease risk, actually. So it sort of had case control study based upon cardiovascular disease risk. And they drew conclusions before the study had finished to say that there was an increased risk of breast cancer, which the study wasn't set up to do. So it was sort of false in terms of evidence in that sense. They've gone back and looked at the information since, and actually it didn't show what they said it showed at that point in time when they looked at the data. So I guess there's lots of information since then that has looked at breast cancer risk. And again, there's varying information coming out. It looks like for combined HRT, so estrogen with progesterone, there may be a small increased risk of breast cancer, very small, less than drinking alcohol regularly, or certainly less than having a raised BMI, so being overweight. And actually, for the newer progesterone, there's evidence still coming, so I'm reluctant to say there's no risk, but we'd call it breast neutrality. It doesn't affect the breast. It looks hopeful that the micronized progesterone, the estrogen, might not confer an increased risk of breast cancer. And this is only talking about combined HRT, remember, on the estrogen-only HRT. So for those people who can have estrogen-only HRT, who've had a hysterectomy, it looks like there may not be an increased risk of breast cancer. In fact, there may be a decreased risk of breast cancer. So the risks are very small, and maybe on some of the newer treatment, completely negligible, but that study data isn't confirming that yet. So the historical information of it causes breast cancer is not right.
Yeah. And also, doesn't it decrease the risk of colon cancer quite
Yeah,
significantly. I can't
yeah,
remember the stat off the top of my head, but it is
yeah.
quite
It
significant,
does.
isn't it?
It does. And it reduces your risk of cardiovascular disease and it reduces your risk of osteoporosis. Breast cancer is a very frightening diagnosis, isn't it? Because we know young women who get breast cancer. But remembering that breast cancer diagnosed on HRT is not at any increased risk of death. And also remembering that breast cancer is not the main cause of death in women. Osteoporosis is a huge risk to women, particularly older women. If you develop osteoporosis, your risk of dying within 12 months for sort of a hip fracture is huge.
Yeah.
So it's putting it within perspective, I think.
Hmm. Yeah,
So
isn't it one in two of us will have some sort of fracture after the age of 50
yeah, and
because of
it's something like 30% then die within a year of a hip fracture. That's not sort of so yeah, osteoporosis has a significant sort of morbidity and mortality issue for women, but we don't talk about that in the same way. I guess possibly because we're often talking about it in older women.
Mhm.
Cardiovascular disease is a bigger risk to women than breast cancer, and we know that being on HRT reduces your risk of cardiovascular disease. When you think about HRT, don't just think about the risks, think about the benefits too. And when you weigh them up, well, for me personally, the benefits far outweigh the risks.
Let's just go back to HRTs for those people who don't know a huge amount about it. If you still have your uterus and you haven't had a
Yeah.
hysterectomy, you need to have the estrogen part of it. And then
Yep.
you also need to have the progesterone part of it. But as you've mentioned, that's to protect the lining of your womb, of your
Yeah.
uterus.
The progesterone part is there to stop the lining of the womb becoming overly thick. Lots of estrogen causes the lining of the womb to sort of grow, and then the progesterone sort of makes sure that it doesn't grow too thick. And then when it becomes thick, it puts you at risk of endometrial cancer. So a lot of the time, we now prescribe progesterone as something called micronized progesterone or utrogestin, and that is a tablet that can be taken orally or vaginally. However, some women, if you have a Mirena for example, for contraception, the Mirena can be used as the progesterone part of your HRT. There is other kinds of progesterone that can be used if you are very sensitive to progesterone. Sometimes we have to swap around your progesterones a little bit to work out what the right progesterone for you is. Generally, though, utrogestin's very well tolerated, probably the lowest risk for breast cancer risk, and can be taken orally or vaginally. Vaginally is off license, but so on recommendation of your doctor, you could try vaginal utrogestin, particularly if you're very sensitive to progesterone.
Okay. And the estrogen part can be taken in various ways as well, can't it?
Yeah, so we generally recommend that you take that through your skin because if you take it orally, it slightly increases your risk of blood clot. So why have an additional risk when there's no need for it because you can take it through the skin. And then through the skin, it can be taken in three main different ways, really. There's a gel, estrogel or Sandrina gel. There's a spray, which is called Lenzetto, and there are lots of different patches. But advocating for an estrogen only patch rather than a combined patch, so you can sort of increase the dose of the estrogen without touching the progesterone. So Estradot is very popular. It's nice and small, or Everil. At the moment, I found particularly at the moment with the estrogen supply, HRT supply issues generally, I'm sort of speaking to the pharmacy saying, what can you get hold of rather than do my usual thing of what would you like, which is a bit of a tricky place, I'm sure. If
And
women are listening to this.
this shortage of supply here in the UK, is that because demand for it has increased?
You've got to assume so. I think there's been some really good education and women are learning about HRT. I'm certainly seeing an awful lot more HRT consultations as part of my day. Might be because I'm a menopausal woman, but I think more likely, I think my colleagues are also seeing it. I think there's good education and women are coming forward and saying, I'm struggling and we are prescribing it. And the supply just hasn't kept up with the demand. But it's a very sad state of affairs, isn't it? That actually women can't get hold of the medication they need. And particularly for some of the women who, have really, really struggled with symptoms, or women with premature ovarian insufficiency, very, recent surgical menopause women who really, really need their HRT. It's like taking away a lifeline for people. It's awful.
It's horrendous. It is shockingly rubbish, isn't it? And it just goes to show where women's health is in terms of the priorities of this country. It's absolutely blimmin' shocking. Thank goodness we've got Carolyn Harris, MP, who is stamping her foot about it and raising awareness. And particularly those women who have had hysterectomies or had their ovaries removed, they absolutely should be recommended to go on HRT, because otherwise, I mean, I've heard so many stories of women just their bodies going into absolute shock, not suddenly having the hormones which has been keeping them functioning.
It needs discussion, really, doesn't it? Before you start to remove someone's ovaries, you shouldn't wait for someone to hit a crisis point afterwards. It's sort of should be part of a planned management, really.
Absolutely. And what about testosterone, Sian? Because again, that's a hormone which isn't licensed, but has been proven to significantly help so many women, particularly in sort of helping for brain clarity and for libido as well, isn't it?
Yeah, it's an interesting question, this one, isn't it? So remembering that testosterone will convert to estrogen in our bodies. So if we haven't got enough estrogen, measuring a testosterone level is fairly useless. So the first thing we need to do is make sure you're well estrogenized before we bring in testosterone. If you're well estrogenized and you still have symptoms, then it is worthwhile seeking out some testosterone. Now, sadly, in the UK, and again, this comes down to that question about what does the sort of nice thing about women's health priorities. The only reason it's licensed for on the NHS is libido. But we do know it helps with muscle, joint aches and pains, development of muscle, the brain function. So there's a place for testosterone use in a lot more situations than libido. But if you want testosterone on the NHS, I would be sure to be mentioning your libido. I think very few women who are perimenopausal and struggling with symptoms have much of a libido. So I'm sure it's not going to be a lie, but I would be mentioning that up front if you're looking for testosterone on the NHS. They would be advocating that they give you the estrogen first, because as you say, we can't check testosterone levels properly until we know you've got plenty of estrogen on board. And then if you've got plenty of estrogen on board, then we check testosterone levels. And depending where you are in the country, you can use something called free testosterone or a free androgen index. And your doctor should be able to look up and work out how to do that for you. And if it shows that your testosterone levels are low, then it's well worth trying some testosterone. It can be a bit of a slow burner in terms of sort of feeling better. I know for me personally, starting estrogen, the joint aches and pains went pretty much straight away, but some of the other symptoms take a bit longer. For testosterone, you're going to give it a 3 to 6 months trial, really, to see if it's helping before you say, well, it's done nothing, and then stopping it. Obviously, if you get any side effects, which they are very minimal, you may change your mind sooner than that. But if you're committing to testosterone, I would suggest that you're thinking about taking it for a good 6 months and try to be patient. I know it's really hard to be patient when you've got symptoms and you feel terrible, but just wait it out, because it may be that it takes a few months for you to start to notice the benefits from it.
Great. Okay. And what we're being told that we can stay on HRT forever, particularly by Dr. Louise Newsom. But I know a lot of women find this very difficult to believe. Shouldn't we allow our bodies to kind of naturally adjust to what is a very natural process? What do you think about that?
I think, again, it comes down very much to personal choice. I think we'll continue to get new evidence. This is much more on the agenda. So we'll continue to get new evidence over the coming years, and that will inform your decisions. And therefore, that's something to discuss at your HRT annually. Some women go on to have pretty much lifelong hot flushes and struggles, and therefore they may choose to stay on it long term. Some women actually just want to take HRT for a few years and then try and wean off it. I think it's personal choice. You're probably thinking around about 10 years at least for the main advantages for your osteoporosis, etc. It may be you can try reducing the dose at that point and see how you get on. And it may be that it's really important to you that you personally want to come off it, and that's absolutely fine. Don't feel like cornered into either end of the spectrum. Don't feel like you're going to see a GP for your annual check, feeling like you have to justify continuing because it's really important and it makes you feel so much better. Equally, don't feel cornered that you have to take it forever, that because people are saying it's so great for you, you have to take it forever. You do what's right for you, taking on board the evidence that's available to you at that point in time.
And this goes back again to the fact that the more informed we are, the more empowered we are to make the decisions which are right for us. Mm-hmm. We are so different, and everybody is entitled to manage this in exactly the way they want to. That's why I want to do this podcast, and that's why I'm so passionate about it, because we just need to have that information ready at our fingertips. I mean, I'm just wondering if there's anything else about HRT which I've missed. Is there anything else which is important to note?
I think I just also remember that sometimes it takes us a few goes to get it right for you. So if you start HRT and you're not feeling great, it doesn't mean that HRT won't help. It just means that we may need to change the dose, the combination, the type of progesterone. We just might need a little bit of time to get it right. Don't feel despair because it doesn't work straight away for you and it did work for your friend. That again comes to that place where we're all different, and sometimes it just takes a little bit of tweaking. And for most, I mean, I don't think I've ever had anyone that hasn't eventually felt better taking HRT, but it doesn't always work first time with the first combination we try.
As a GP, when someone comes in to see you displaying symptoms and is looking for some sort of help, we know that there is a 10-minute appointment. And quite often, women don't feel like they get the support they need. It really does feel like a bit of a postcode lottery. I, for one, have been incredibly fortunate where I live. I've had all the support I've needed and I have no complaints. Yet I hear so many stories of women being told that they couldn't possibly be perimenopausal because they're too young, or being put on antidepressants when they feel that isn't what they need. What would you say to these women? What is the best way they can prepare for an appointment with their GP to try and get some support and answers that they are seeking?
I guess one of the first things I want to say is I think a lot of GP surgeries and GPs are becoming increasingly educated and are very willing and knowledgeable and want to help. So sometimes I feel the message is that GPs will never give you your HRT. I've certainly had someone ask me recently, why can you only get HRT privately? And I sort of looked at them in horror, didn't even know what to say. So do think you can get your HRT from your GP, because you can. Equally, I think it is also true that menopause education has not been a priority for training in general practice historically. And I think sometimes you will come face to face with someone who doesn't really know enough about menopause. So being really well educated yourself will help. So getting onto the Balanced Menopause app, reading around, having a think about what you personally want from the appointment on your way in. Don't dismiss what your GP has to say, because it may be that you think you've got menopausal symptoms, but as we've said, those symptoms are so wide that sometimes other things like thyroid problems or anemia, or there's lots of other things that might cause your symptoms. So if your GP is worried and wants to check for the other things, please do trust them to check for the other things. But if the other things are not there, then be strong in your view and hold forth about your menopause and ask for the help that you need and advocate for yourself. It's really, really important. I think there's something called the Green Climacteric Scale. So it's green with an E, climacteric scale, that you can go to, that has a list of menopausal symptoms that you could take in to show your GP. The Balanced Menopause app has similar sort of symptom checkers that you can take in to show your GP. Anything that you can help them. It is a 10-minute appointment. In reality, most of us don't stick rigidly to the 10 minutes because it's not realistic. But I find it very hard to do a good menopause consultation in less than sort of 30 minutes, to be honest, when you're first seeing a woman. You need to check her symptoms, make sure you're happy there's nothing else going on that you're missing, look at the bigger picture in terms of how it's affecting her, look at what she's hoping to get from the consultation, talk through the HRT options, talk through the benefits, the risks. That's not a very quick appointment. So anything that you can do in advance of that to prepare for those conversations, you can maybe say to your GP, well, I've actually had a look and I know about the benefits and risks. I've looked through the women's health concern and I understand what's happening. That will help the GP to process more quickly. But if your GP, and that's just with a well-informed GP who's ready and willing to help, that's just to help them get through the appointment. But actually, more is the situation where you get there and you've got someone who isn't. I guess know that you well within your rights to ask for HRT. Know that you can always try a different GP. If the surgery that you're registered at is not offering the care that you need, you can register with a different practice. I know it's not always possible depending where you live in the country, and if there's big practice areas, it's quite hard, but shop around. And if you're not getting the help from the practice that you need, and you're not getting the help from the GP, and you can't get another GP to help you, ask for a referral to an NHS menopause clinic. Again, there's a bit of a postcode lottery around that across the country. You've got to, it's a shame that I have to say this, but to be your own advocate in this situation and know it's okay to ask for it and it's safe to ask for it in the majority of situations.
So, Sian, if women feel like they really want to have HRT and they are being refused by their GP, what do the NICE guidelines state in terms of who can have it? And does it get to a point where women actually can almost demand that they have HRT, particularly after the age of 45?
So the NICE guidelines are there to as clinical guidelines of best practice in the NHS, but best practice is remembering that the NHS is a system with limits, in the sense that there are cost implications of any of the treatments. So they're not going to recommend something that's incredibly expensive necessarily if they don't feel the benefit is sufficient for the cost implication. There are guidelines there to tell us what best practice is, and best practice says that using HRT and managing menopause is the best thing to do. So it's the best thing to do if you're feeling low and you've no history of depression and that's happening in your perimenopause. The best thing to do is to give HRT, not an antidepressant. I think women who are perimenopausal, who are clearly perimenopausal, no other cause for their symptoms being found, are well within their rights to say that they want HRT, yes.
Even if they're under 45?
I think even under 45, if no other cause has been found for the symptoms and they have a number of symptoms, I think there is no reason why they can't have a trial to see if it helps. And if it, no reason, as long as you've sort of looked at other risk factors for HRT, then I think it would be very reasonable to ask for a trial of HRT.
Thank you for clearing that up. So many women, which we don't really hear about, we talk about, do actually manage to get through their menopause transition relatively smoothly. They don't need HRT. Their periods just stop. And wouldn't that be a wonderful world if that was the case for everybody? So this is what I always wonder about. If there are women who can do it without HRT, why can some of us not? And how much is it down to our lifestyle and our choices that we make, which make our symptoms much, much worse? I don't know what your thoughts are about that.
I don't know, if I'm honest. I promise I see lots of people of all of these examples, but I can think of at least a couple of women in the last week who I've seen who are doing regular weight training, who are eating incredibly healthily and being very conscious, not drinking any alcohol, being very careful with their sleep routine. They are, they are the picture of everything that you should be doing for self-care, and they are really, really struggling. So I don't think you should allocate blame based upon lifestyle in the symptom pattern with menopause. I think it's much more to do with genetics or hormones, your makeup. Lifestyle inevitably will help a little, but how much? And often not enough. I think you're an example of that, Polly. You're a healthy living, exercising, self-caring human being who has needed HRT. So I think bringing lifestyle in as a blame factor or as an attributing factor for why your symptoms might be worse, I think is unfair. And actually, sometimes when you're feeling terrible, all you want to do is have a glass of wine and sit in front of the telly eating a bag of chocolate. And sometimes you need a bit of HRT to break the cycle, actually. So I don't know if there's what degree of relationship it is, but I can tell you it's not that strong, because I see plenty of very, very clean living people that, I would love to say I lived as healthily as them, and who really, really need HRT.
Yeah, it's so fascinating, isn't it? Sian, thank you so much for your time today. I've really appreciate it. It's been really lovely hearing from a real life GP, someone from the medical profession, and your take on all of this. And yeah, it's just it is such a topic which I think just we all just need to keep learning about, and the more we know about, the better placed we are to manage it and have a really positive perimenopause. So my final question is always to all my guests: what is one practical, actionable tip that you personally would give to other women in order for them to have a really positive perimenopause?
I think it's probably a tip that I give people for most things, which is education. Education for yourself so you can recognize the symptoms, education for yourself so you know you have options when you don't feel you have options. Life feels very, very hard. And you can educate yourself, and then you can educate others to help your friends as well. Share that knowledge and share it forward. But with information comes choice, really, I think.
Yeah. Amazing. So, Sian, if anybody wants to get in touch with you or find you, how can they find you?
I can only be found in my own practice doing general practice on the NHS in Clapham. So no other agenda here at the moment. I'm on Instagram, just sharing a little bit of information at your menopause GP. I hope you find the information you need from your own GP. That would be my hope for you.
Great. Well, thank you again so much for your time today, Sian.
Thanks, Polly. Bye-bye.
I hope you found this episode informative, helpful, and I hope you're a little bit clearer about HRT, the risks, the benefits of it, because it can be quite a daunting subject, but hopefully Sian has really helped clear some of that up for you. As she said, knowledge is really, really key, and getting informed, a really good place to start if you think you're perimenopausal, is to understand what is going on for you at this time. And a great place is to get a list of all the different symptoms and really mark off any which you think apply to you. And then you can monitor them over time and see if they're improving or getting worse. And you can download a list like this from my website. So if you go to pollywarren.com/perimenopause, you'll be able to download a list of over 35 symptoms and really see which ones apply to you. So just to recap, you can catch Sian at your menopause GP on Instagram, and you can catch me at Polly Warren Coaching, or you can send me an email at info@pollywarren.com. As always, I would be super, super grateful if you feel like you would like to leave me a review. You can leave a review over on Apple Podcasts. You can only leave a review on Apple, not Spotify. I'm not sure why, but that's just how it is. So it would just be amazing. Or what would be even more amazing is if you feel like a friend would benefit from learning a bit more about HRT and listening to this episode, you could tag your friend in Instagram or send her a message and copy her in this. That would be amazing, because we all need to help educate and inform each other as much as we possibly can. It all helps. Anyway, that is it for another week. Thank you so much for listening. I know how super busy you all are. Life is a juggle, and to take the time and listen to this podcast really does mean the whole world to me. So thank you so, so much. Have a really wonderful week. Hopefully the sun is shining wherever you are, and I will see you next time. Bye for now.